Hey guys, my name is Ben. I'm a MLT to MLS bridge student, and here's going to be my case study for micro. So let's get started. So just some initial patient history. Got a 79-year-old male with a previous diagnosis of late onset combined immunodeficiency of undetermined etiology. He's a non-smoker and he lives in Wisconsin. And an important thing to note is he had 2 previous opportunistic infections in 1 year. So already not off to a good start for this guy. He's immunocompromised. He's going to be prone to a lot of different organisms, and we'll see here in the next few slides. So he's going to go to the emergency department for an evaluation of a maculopapular rash and a fever. And so the rash was to be suspected due to oral antibiotics, which was intended to manage cellulitis of the lower left leg. But the patient's family had also noticed he had a altered mental status with a dry cough, and shortness of breath was noted as well. And so they're going to go ahead and admit him and make sure he's progressing well. But a chest radiograph was done on day 1, which was normal. But on day 5, they did the same thing, and it showed upper right lobe opacity, which means there's some haziness seen on the X-ray. In the right upper lobe of the lung, but it could be pneumonia, could be another sort of infection. There's a lot of different things it could mean, but it's not very diagnostic of anything yet. But a respiratory virus panel was done on sputum on day 1 and showed infection of rhinovirus and parainfluenza 1. The article is pretty unclear as far as to whether like a culture was done or a gram stain, but that's all it said was done on day 1 as far as with the sputum. But on day 5, the patient's cough became productive and his brown sputum was noticed. And that's when the BAL was collected. And they also did a urinary Legionella pneumophila antigen test, which was negative. So it was assumed that the patient had a nosocomial infection, which is basically a hospital-acquired infection, specifically pneumonia. But patient was started on antibiotics such as vancomycin and tobramycin. And we know vancomycin is going to treat gram-positive organisms, while tobramycin is mainly going to be used for gram-negative organisms, particularly Pseudomonas aeruginosa, but it can also be used to treat Staph aureus as well. And unfortunately, on day 10, the patient's going to pass away to cardiopulmonary arrest, which was secondary to septic shock. So at this point, the patient was very sick, and he succumbed to an infection. So on day 16, the BAL ended up growing out Legionella pneumophila, and testing was later to be confirmed as serogroup 3 by a direct fluorescent antibody test, or DFA. So you might be wondering, why was they not caught in the urinary test? So the urinary antigen test for Legionella only tests for serogroup 1, in which, in this case, the BAL only recovered serogroup 3, which was done by the DFA. And so just some serology for you, because we all love serology, but you're going to start out with your bacterial antigen, and then you're going to isolate it, and then you're going to, well, you probably don't have to isolate it, but you're going to attach a directly labeled fluorescent antibody to the antigen, and then it's going to fluoresce under the microscope, and you're going to be able to see it. So just some fun facts for you. It's a major cause of community-acquired pneumonia. Your community-acquired pneumonias are going to be strep pneumo, mycoplasma pneumoniae, chlamydia pneumoniae, and then legionnaires. So those 4, it's part of that group. It's a thin, faintly staining gram-negative bacillus. It's going to come from water sources, which is going to be important in the coming slides. It's not transmitted person to person. You get it by inhaling infectious aerosols. So it's going to be airborne. And like we've mentioned previously, patients immunocompromised, he's going to be susceptible to these types of infections. And so there's 2 parts to the Legionella bacteria, 2 main pathologies, I guess. Legionnaire's disease is going to be the more severe infection. It's extrapulmonary infection. But Pontiac fever is going to be a little bit less severe. and it's not going to involve pulmonary. So, and we learned this in the lecture as well. As far as your identification, it's going to be recommended that if Legionella is suspected, to put it into a BCYE media. And basically that stands for buffered charcoal yeast extract. It's going to provide L-cysteine and iron for the best growth. It's very selective for Legionella, and it's going to grow all, I think, like 16 serogroups. It should, anyways. I think there's like 16, but as you can see, big white colonies on here, and yeah. So as far as the workup process, it's going to be difficult to isolate on basic means of media. So blood agar is not going to have any growth after 5 days, and it's going to require you to culture to BCYE in order to see definitive colonies. And as we mentioned before, urinary antigen tests can be done on serogroup 1. You can't determine which serogroup it is, totally based on like symptoms and stuff like that. So, but most of your Legionella infections are going to be serogroup 1, the majority anyways. And so this is going to be a good screening method. I think there's like 2 urinary antigen tests. They test for like strep pneumo and Legionella. In my lab, we do them both at the same time. That's kind of like a combo antigen test, but yeah. So, but you can also use PCR to molecularly identify it, and so that's going to be like obviously your very definitive, Legionella. So after the patient passed away, they're going to go to the patient's home and do a little study just to kind of see what's going on. They're going to take cultures from 2 shower heads, and it ended up growing out Legionella. And so a deep cleaning was done on the air system, and it was thought to be completely decontaminated, but they cultured it again, and it was still growing. It was still growing Legionella. And so residents of the home were advised to seek medical attention if they started developing any symptoms of possible infection, but none of the other residents of the house developed any problems relating to Legionella. And this just kind of goes back to, patient's immunocompromised. He's going to get these types of infections in this rare serogroup. But I want to stress the importance of getting a respiratory specimen early in the admission process, I guess. Because, in the article it says they first did like culturing and stuff like that on a BAL on day 5. And so, who knows if they would have caught it on, or if they would have collected a respiratory on day 1 or even day 2, if like they would have, suspected that's, nothing's growing on BA, this could be fastidious, or, there's a lot that goes into it. But I thought a little interesting fact was that rates of Legionella in Wisconsin have increased by more than 400% since 2010. And, I think some of, there's not too many correlation, I don't think, between, just because it's Wisconsin, but I think, some causes could be like outdated architecture or outdated water systems. And so I think it's important to raise awareness, if you have an older home, to get that like tested in, to make sure, you have a clean and filtered air system, that you're not spreading any of these infectious bacteria. But anyways, here's my sources, and thanks for watching.